This is the Doctors Making a Difference podcast, living with metastatic cancer, highlighting patients, doctors, and researchers who are fighting to win against cancer. We are privileged today to welcome Dr. Gina D'Amato. Dr. D'Amato works at Sylvester in Florida. I'm so pleased that she's willing to take the time to come and talk about her interesting cancer research. She's not only a physician, but a cancer researcher. And as listeners of this podcast know, this is very interesting and near and dear to my heart because I'm a cancer patient and a physician, and I just really appreciate what Dr. D'Amato is doing. And anyway, would you mind, Gina, do you mind if I call you Gina? Do you mind introducing yourself to our audience?
Sure. You're welcome to call me Gina. I'm very excited here, and thank you so much for having me on your show. My name is Gina D'Amato. I'm a sarcoma medical oncologist, professor of medicine, clinical lead for sarcoma medical oncology at Sylvester Comprehensive Cancer Center at University of Miami Miller School of Medicine.
Oh, that's wonderful. Well, and how long have you been there at Sylvester?
6.5 years now. Seems
Awesome.
like yesterday.
Well, it goes by fast when you're doing important work. Would you mind kind of sharing a little bit of your journey? I want to know, how did Gina D'Amato choose to become a doctor and then become a sarcoma specialist in Florida? I mean, we all arrive in these interesting places as physicians, and it's interesting to hear your journey. Do you mind sharing briefly your story of how did you end up doing this?
Yes. So if you're a good student, and you know this, and most doctors know, you're a good student, and then your parents are saying, oh, you should be a doctor because you're a good student. You like science and math. So that was a little bit of the background, but really I was very interested in cancer from very early on when my grandmother passed when I was in third grade of a GYN cancer. And then when I was in high school, my sister was her senior year and she was diagnosed with Hodgkin's lymphoma. And I actually had around the same time had a benign condition called lymphomatoid papulosis. And they are related. They're both CD30 positive lymphoproliferative disorders. Of course, she had the cancer and had to go through chemotherapy and everything, and I didn't have to do any treatments. And so, of course, I became fascinated in cancer at that time. So then that's where I went to University of Miami, was an undergrad, and then got into a medical scholars program and went to medical school. Did residency at University of Miami. So actually I was here for 10 years, 18 years ago. Well, more than 18 years ago, then came back 18 years later. I went on to do my fellowship at Moffitt Cancer Center, and I was really interested in lymphomas. I was really interested in cutaneous T-cell lymphomas because of my background with the lymphoid papulosis. And I had an NIH grant. I had the K-12 grant to study this, but my mentor left to become the cancer center director of Penn State. So then I was kind of without a project. And at the time, the Moffitt did not have a sarcoma medical oncologist. So this is early 2000s, and there were a limited number of sarcoma medical oncologists. There were, fair number, but still rare orthopedic oncologists. So the orthopedic oncologist there, Dr. Letson, had been trying to recruit somebody. So he had actually been trying to recruit Dr. Trent, who was at MD Anderson. And he had been trying to recruit all the experts, and they said, no, they're not moving their institution. So Dr. Trent said, why don't you, instead of trying to recruit a sarcoma expert, why don't you take a fellow and train that person? We can train that person, and we can train them remotely. This back before we had remote learning. And that's how it started. When I was in high school, I was close friends with someone that played at University of Miami. So my sister went to University of Miami, and then I joined her 2 years later. And Brad was in her class, but I hung out with him, and he was playing football for University of Miami, and he broke his femur. And then when they took him off the wait list, that's when they found the sarcoma. And he was actually treated at University of Miami by Dr. Benedetto. So when I was in medical school and residency, I would follow Dr. Benedetto around, and he did sarcoma. But again, I still had that interest in in lymphoma. So then when I was at Moffitt and they were saying, oh, we need someone for sarcoma, I said, well, I do know a little bit about sarcoma. And then they said that there's an international meeting called CTOS, and it's in Barcelona. And then they said, it said international travel. And I said, okay, I'm
Oh
in.
yeah.
I know a little bit about sarcoma, international travel. But I liked that it was rare and that there was a huge unmet need. So I did like that, and I actually had all the world's experts train me. I had George Dimitri, who is at Dana Farber, uh, Bob Benjamin at MD Anderson, Dr. Trent at MD Anderson, Bob Mackey at Sloan Kettering, Larry Baker at Michigan. These were the top medical oncologists. And I would see patients with a preceptor of lung cancer, Dr. Williams, who's really very nice and very intelligent. And we built the program there at Moffitt. And I was there for about 4 years, 3.5 years, 4 years, and then I moved on to Emory to build a sarcoma program there, and after that, I went to was actually stayed in Atlanta and was working in a private practice, but it was a kind of this hybrid private practice where I was able to still see sarcoma patients. Now, while I was going there, Dr. Trent from MD Anderson was recruited to University of Miami Sylvester to build a sarcoma program. And so I said I would love to work with him, and he built this big program and then eventually recruited me back. So I'm happy to be full circle, kind of similar to your story, a little bit different, but full circle back in. So 18 years later, came back here and really thriving and really loving the opportunities, because when I was in private practice, it was very good. I was able to see patients and I did have some clinical trials, but the research opportunities here far exceeds any place that I've been. And Sylvester has been extremely supportive in our research efforts and to build a sarcoma program, because not every cancer center really puts the support behind building a program, because it's rare and there's not a lot of experts. And just to be frank, you get more money and more research funds from breast cancer, colon cancer, prostate cancer. So that's and that's where a lot of the cancer centers, kind of focus, and they don't want to give special attention to sarcoma. But at University of Miami Sylvester, they're really very, very supportive.
Well, it's interesting. Like I say, most of the people listening to this podcast are physicians. I think everybody can relate to the reasons why you choose the job you choose. It's who you know, and it's the opportunities that come up, and it's your personal experience. It's your family member that had a cancer and the type of cancer, and your grandma. And I think everybody can go back and say, hey, why do I do what I do? Because somebody along the way made had this powerful impact on me and changed my life, and I'll do whatever it takes to make that difference. And so you've kind of followed that same path, and now you're back studying a cancer that type of cancer that's more rare. And for those of us that unfortunately have a type of sarcoma, we're just so thankful for that research that's being done, because as a physician, you get to take care of patients, in vivo, but you also get to do benchtop and clinical research that makes a big difference. And the world of cancer is expanding tremendously, and you get to be right at the cutting edge of that. How is that?
I mean, it's really great because sarcomas, again, just in comparison, 300,000 Americans get diagnosed with breast cancer every year, and only 17,000 with sarcoma. And unlike breast cancer or colon cancer, where there may be a few different types of those cancers, sarcomas, there's over 100 different types of sarcomas. So each individual sarcoma is even more rare, right? So if you have, for example, the solitary fibrous tumor, which is 2% of sarcomas. So maybe if I did, we don't even have the numbers, but maybe 300 to 400 Americans get diagnosed every year. So each time you work with a sarcoma patient, each individual sarcomas are rare as well. So you're rare and then even rare. And I do like it. It becomes frustrating because there's a lot of unknown, but then that unknown is actually very good because, you just have endless amounts of questions that you can be answering, and you know that you're really making an impact in people's lives. Any little thing, any needle that you move, you're really making huge advances because of the uncharted territory it's just all uncharted territory. Every time you try to do a research project, it's never been done before. and,
Right.
and simple things that, if you go to a breast cancer conference or a colon cancer conference or just ASCO, which is American Society of Clinical Oncology, and you peek in on their presentations, and then you go to the sarcoma conferences, you're very humbled
Hmm.
because they're doing science that's probably 30 years more advanced than what we're doing. But we're getting there, and we're getting there with the support of institutions and the support of private donors. That's how we're getting funding, and that's how we're able to advance the needle.
Well, it makes a big difference. My wife and I were talking this morning. We went on a bike ride and talking about, hey, I have metastatic solitary fibrous tumor, which I hate. I don't want to have this disease. I didn't do anything to get it. It just showed up. And the thing we've decided to do is just live life like normal and just pray and hope that science stays one step ahead of it. And we are at the kind of at the molecular stage of understanding on most things. And the more we understand about it, the more treatment modalities present themselves. And it is kind of an exciting time to be a researcher. It's never a good time to be a cancer patient. I don't think of anybody that wants to have that. But that's what you kind of hang your hopes and your prayers on, to say, okay, please stay one step ahead of this, because we've gone from systemic therapies to really targeted therapies. And the more that we understand, it asks 10 more questions, but the more we understand, the more treatments can be devised. And then hopefully you get more funding from both our government funding, private donor funding, because the chance of making a huge change on this is huge. It's just really a really kind of a cool time to be in the middle of that sort of research that you're doing.
Yeah, I mean, I think, I've been, an oncology. I finished my fellowship in 2004, so over
Hmm.
20 years now of being an oncologist, and the changes and the improvements that we've made is really phenomenal. And I tell patients, listen, we're so close, and we've made major advances, and the advances that we've made, maybe it was in this direction, but now that we have all the technology and the gene mutation profiling, and the all the advances that we've done with computers and technology, now we're going like this. So
So
we're
that
going to
trajectory
really,
has become much steeper.
trajectory is going to be so much higher. And I tell patients, look at this cell phone, look at this smartphone. We didn't have this 20 years ago. This is a computer, this is a calculator, this is a camera, this is a second brain. I call it my second brain. This is my second. Okay, what do I, Siri, tell me what to do, where to go, everything. And it's in this little box that I can put in my hand. So if we can do this, we are going to have way better treatments. We're going to have cures, and it's going to be in our lifetime. And that's what and I think the research that we're doing now is going to prove that. I think we're smarter. I think we're analyzing it. In the past, we just did chemotherapy, right? Chemotherapy just kills cells that are growing and dividing because we didn't really understand what's driving these cells to grow and divide. But now we have to understand at the molecular and the genetic and the epigenetic level what's driving these cells to grow and divide, and how do we stop them? How do we stop? Why are the genes mutating? Why does it happen? Can we prevent it from happening? And if they are, what's the result of that genetic mutation? And then how do we stop it? So and that's what we're doing with this solitary fibrous tumor initiative, the Horowitz solitary fibrous tumor initiative, that we have. Patient of mine, Joel Horowitz, the best guy in the whole world, I would say. besides my family, what can I say?
Yeah,
But
right.
maybe he's better. I don't know. Don't say that, but hopefully they won't listen. Anyways, Mr. Horowitz, was committed. He says, listen, I want to find a cure for a solitary fibrous tumor. I'm like, okay, well, we know how to do it. We just need the money and the resources to do it. And I said, what we need to do is we need to, number one, try to figure out what causes it, right?
Hmm.
But at the same time, try to figure out better treatments once it's spread, and then understand the genes and the systems that are in place of causing it to spread and being sensitive to treatments. So it's a real widespread research project. One we've started in the lab. We're growing cell lines. We're trying to create cell lines from the human tumors, which is very hard. Sarcomas, if you can buy, I can get a cell line from breast cancer on the phone in 30 minutes. There's so
Hmm.
many breast cancer cell lines, colon cancer cell lines. Carcinomas are easy to grow, and there are so many, and of course it's more common. Sarcomas cell lines are very hard to grow. We have a lot of tissue, but they're very hard to grow. And so we're working on building cell lines directly from cancer, from the tumors itself. While we're doing that, we're actually engineering the mice to develop the solitary fibrous tumor by injecting them, which is very complex. And I let Dr. Lombard, what I did was I said, I know how to do it. I know how to get the smart people to do it. Okay. I
Right.
will get all the laboratory researchers. I'm an MD. I'm not an MD PhD. Dr. Trent's an MD PhD. Dr. Hornacek, our orthopedic oncologist, MD PhD, and we have MD PhDs in the lab. I did do a little dabbling of lab work when I was at Moffitt. Again, Dr. Trent would give me his cell lines, and I worked on them, but I was always called to the patients. So I don't work directly in the lab, but I've got the smart people to do the actual lab
Right.
research. We recruited Dr. Lombard from University of Michigan, and he works in his epigenetics lab. So he's been able to engineer these mice. So solitary fibrous tumor, just a little background, it's a rare sarcoma. Sarcomas are cancers of connective tissue. Again, 17,000 uh, cases every year of sarcoma, and about maybe 340 roughly US solitary fibrous tumor. Usually occurs between ages 50 and 70, but we've seen younger, we've seen older. And it could start out anywhere in your body, extremities, retroperitoneal area. It could start out actually in the brain. And if it starts out in the brain, then it's called hemangiopericytoma. And they realized that solitary fibrous tumor and hemangiopericytoma is actually the same thing because it has a specific gene mutation that's a chromosomal translocation between the NAB-B2 and the STAT6. So basically, STAT6 drives the cancer cell to grow and divide, and it's supposed to be stopped. But instead of being stopped, NAB2 gets attached to it and drives it further. And so if you inject mice with the NAB-B2 STAT6, you can get now you have a model of a solitary fibrous tumor model. Maybe not as good as growing cell lines and injecting them to mice, but pretty good. And so while we're trying to get the cell lines, we've developed these mouse models and we're testing. And we also have, and we can derive cell lines from those. We've also worked with researchers from around the world, Dr. Martin Brodo in Spain, and then there's another patient, Heather Huanga, that's in Dallas, and they have cell lines. So we've used their cell lines as well while we're building our own, and they've been very, very helpful and collaborative. And so we're growing these cell lines, and then we're testing them on thousands of different drugs to see the sensitivities of the drugs. And then we do have a couple of hits, and then once we have shown that these drugs are effective in the cell lines and in the mouse, then we're going to take it to the clinic. And part of the grant initiative is to have a clinical trial. We're thinking that it's likely going to be with an HDAC inhibitor. That's so far, but we initially built the thought that we would develop a drug against STAT6, a STAT6 inhibitor. That was the original plan. But then as we're studying it more and more, we're realizing that that's going to be too difficult to be able to the way the molecular driver is, it's not really STAT6. So that's why we wanted to do some laboratory work before we take it directly to the clinic, but we're still working on that. We have some other potential leads. So while that is going on, we have developed a patient registry, which I'm very excited about. We just enrolled our first patient on it, and we're really wanting to spread the word about this patient registry. Basically, it's going to be every patient. The goal is to have every patient that's ever been diagnosed with solitary fibrous tumor part of this registry. And they will go on to the website, and there'll be someone that can help them fill out the information. It'll be a survey where they'll be asked questions and trying to figure out what causes it. What are the causes? Is it hereditary? So we want every patient to go to the genetic counselor and get germline testing to see do it was this hereditary, and then if it's not hereditary, then it's environmental. Mr. Horowitz was exposed to 9/11, the air quality there. So, and we know that burn pits are associated with sarcomas. We know Agent Orange, which is an herbicide, is associated with sarcomas. So we want to get all that information. Anything. Could it be a virus? Could it be our patients that have autoimmune disorders? Are they more likely? There has to be something. And I think the more data we collect, the more information. Did you grow up in a certain area? Was something in the water? So we have questions like that. Where did you grow up? What are your ancestors from, right? So not just what's your nationality or what's your race, right? Because you're white, I'm white, but we look very different. I'm Italian descent. I don't know what your descent is, but you don't look Italian to me.
All
Not
Northern
really.
European. We sunburn too much.
I mean, you just don't look Italian. I don't know why.
No,
But, you're in Idaho, okay? So
that's
it's
right.
going to be Northern European, right? So we're different, even though if you fill out the race, we're Caucasian. So that's the
Right.
things. In Miami, we have such a diverse population, and we have a lot of Black. But Black is not African American because they're Caribbean American. They're from Haiti. They're from Dominican Republic. So it's a different environment, and what was their environment, and so we have. Right now, we're starting within University of Miami, the registry, and and of course, we're going to be opening it up globally. So we really want to spread the word about this solitary fibrous tumor registry. And so I think if we try to get to the basics, like maybe we can find some causes, then we have the germline testing. How hereditary is this? We don't even know. Then we have working with the cell lines, growing them, understanding the molecular processes. So we have genetics, and then we have epigenetics. So genetics is looking at the genes, right? And then the epigenetics, well, what's driving these genes? It's not just the genes. Genes turn into DNA makes RNA, makes proteins. What's driving these proteins? How are they working? So we have the epigenetics, and hopefully we'll be able to. And then also we have 150 samples, which is a lot for solitary fibrous tumor, of patients that have been seen at for about 20 years. And we've got the blocks, they're tumor blocks, and we are sending it up for molecular profiling to Caris. We have a contract with them, and we'll have full molecular profiling, and they'll probably have the data maybe 2 or 3 weeks. And then I have some medical students that have gone through the charts and have all the clinical data on those patients, when they were diagnosed, where their primary tumor was, what treatments, how did they respond to the treatments. And we can potentially build like a gene library, so to speak, so that if we had that data, we could see, Okay, and so in the NAB-B2 6, the NAB-B2 STAT6 chromosomal translocation, which is pathognomonic for the disease. You don't have
Right.
solitary fibrous tumor if you don't have that gene mutation. You might have been diagnosed with it. We send it for molecular profiling. You don't have it. Sorry, you're in another category. It may be good news for you, maybe bad news for you. I don't know.
Right.
But but there are 13 variants of this. Okay, and we know the most common variants are this exon 2, 4, whatever. I don't know if you want to get that much into the weeds of this, but the data that we have done before, just on other samples, international samples, we have there have been two studies, one a smaller study, we did another study where we could see the variant will correlate with where the primary tumor was. So if it's in the
Oh,
brain,
interesting.
it's going to be more like 16, 17. I may be stating this wrong, but and then if it's more in the extremity, it's whatever 4-2 and things like that. So we know that it can correlate with the primary, but what else does it correlate with? Does it correlate with response to treatment? You're on Timidar Avastin
That's
regimen,
right.
which is the regimen that Dr. Trent, who is my longtime mentor, actually developed when he was at MD Anderson, based on primary brain. And so if you have a certain variant, are you more likely to respond or less likely to respond? Or if you have a certain gene pattern, are you more likely to respond or not? Because we also have other treatments. We have Votri, Pazopanib, and some others. So we could potentially gear your treatment based on your gene signature. And so collecting this information is vital. So that's all part of the project. So very, very exciting. And this is what we hope for, because I have patients come to me and I was like, okay, well, we'll try this, and then if this doesn't work, we'll try this. Unfortunately, I don't have a blood test to tell you, oh, you have this enzyme in your liver and you have this gene pattern, I'm going to give you X drug. But if we collect the information and we study it, we will that will happen. And then I'll be like, okay, Dr. Grain, okay, let me analyze the whole thing. Okay, this is your molecular signature. You have this liver enzyme B, that means that you're going to metabolize this drug better, and then you're going to be on this medicine and whatnot. So that's like the near future. And then, of course, the ultimate future is, can we do gene therapy? I think the ultimate goal would be to do gene therapy against the NAB-B2 STAT6, or if we can find out why someone developed that mutation, how someone developed that mutation, and can we prevent it?
Yeah. Well, I hear the excitement and passion in your voice as you talk about it, which excites me as a patient. I'm like, oh, good, she's looking into this. But I'm thinking back, like, you obviously were very interested and tuned into cancer from way back. But I remember like going over all the different subtypes of sarcoma in a class in medical school and thinking like, well, that one's rare and that one's rare. I got to pass the test. And I knew about them, but like it's just not the same level of engagement as when you're like, okay, now I have this disease, or I have a family member that has this disease. And I talked to another oncologist, and somebody else told me that it's not when you get it's not if you get cancer, it's when you get cancer. Cancer is so common. If you live long enough, you're probably going to get some type of a cancer. And so the more we understand about this, rather than having this catch-all like, oh, cure cancer, which is sometimes put out to the lay public, it's more like, okay, of these however many thousand diseases of cancer that are all unique but share some features, what can we do and how can we change it? And I think, just like you said, going from systemic therapy where we're just using chemotherapy drugs that stop rapidly dividing cells to gene therapy and understanding the genetics of specifically behind those tumors. I mean, it's life changing, and not just for the patients who have it now, but for future patients. And then that research can be extrapolated all across the world. People get this disease, and now we have an understanding at the molecular level. And so, anyway, thank you so much. I love the passion and the drive and the excitement for what you're doing. What would you find? What do you find are your biggest barriers to this research? I mean, obviously, you have this really brilliant team of people collected from all over the place to study this rare cancer. What are the biggest barriers you find?
I mean, I think the biggest barriers. I mean, if you're working in a lab, you have to do 100 experiments to get one to work, right? So
Right.
that's why I kind of stay out of the lab. I think and everything is always slower than you think. To grow a cell line, for example, I mean, it's an effort. We have to whenever there's a surgery that's going on that we know that's going to be a sarcoma, solitary fibrous tumor, we get in the troops, and then we collected it and we have it in the lab, but it takes a long time because solitary fibrous tumors are not very aggressive and they grow very slowly. Some can be
Right.
aggressive, but the majority grow slowly, so it takes so long. So even if you collected a sample from July, you don't have anything until December, and you that's grown enough, and then you still have to test it because it could just be regular fibroblasts, and then you have to test it to have the mutation. And if it doesn't, so it just takes a long time, and so there's a lot of effort, and then your yield could be low in that. So that's a little bit on the frustrating start. But then again, of course, we've pivoted from we've pivoted and done other research in the lab to kind of counteract that it just takes so long to grow these cell lines. Also, the registry part of it was I wasn't putting as full of effort because I was seeing so many patients. So I really
Right.
had to, I wasn't getting paid per se, for the research. And then finally I had to say, okay, I really need to actually put more effort in and see less patients so I can really put the time in to write the protocol, because you have to get it approved by the IRB, and you have to write the protocol, and then you have to get the flyers out, and the flyers are approved by the IRB, and then you notice a mistake on the flyer, like we had the original flyer and then it was like the wrong website, so I'm like, we can't have these flyers, and then every time you change it you have to go back to the IRB. And then so it's just been time consuming, all the paperwork that goes in, at least into the registry. And it just takes longer than you think, and you just want it right away. But, in medicine and you just know you can't there's no quick fix, right? Everyone wants a quick fix. But I think the progress is slowly being made, but just a lot of, still, even if, now granted, it's not when you apply for a grant, an NIH grant, that's extremely rigorous, and the amount of
Hmm.
paperwork that you have to do, and the red tape, and then this. I don't have that red tape, which is very nice, but it's still, and I was like, oh, I don't have to do as much paperwork because it's not a grant, but you still have to do the paperwork. You still have to make sure that it's a protocol and that
Right.
people are abiding by the protocol, because we're still doing research. It's just, and we still need to make sure that it's a solid, and that that patients are worried. They don't want their data being spread everywhere. So we have to make sure that everything is secure and safe for the patients to be able to share their data. So that takes a
Sure.
while. Developing the website, we finally have a website up. That took some time, and so everything kind of takes time. But I think the barriers are much less than if you have a federally funded grant, because you have to spend so much time writing the grant, and then you only have maybe 9% chance of getting the grant. Whereas this, we wrote the proposal and we were able to, start right away.
So what would you say on the registry? Are you at this stage where you want that to be shared, and do you want me to put it in the
Yes,
show
yes.
notes? I mean, go
Want
ahead and
to
tell me
do
what
it.
it is, and
So,
then share with me the specific website. Tell it to me, and then let's put it in the show notes and make sure, because
okay, let me
while this is a
see.
rare cancer, people like me have it, but this is
Yes,
going to go out to lots of doctors, and somebody out there is going to find another patient with
yes.
solitary fibrous tumor, and we need to get them connected with a sarcoma center and a registry and a research team so that we make sure that the next generation of these treatments aren't just systemic, but that are a little bit more focused. So yeah, what would you
Tell
direct us
you.
toward? And then just go ahead and tell me like what it is, the Sylvester flyer, and then we'll put it in the show notes.
Okay, that will be good. Yes. So right now the survey is open for, and the registry is open for patients, so University of Miami Sylvester, and because it was easier to open up through the IRB that way and then make it global. But We can register you as a Sylvester patient, and then we can get you in that way. Or, obviously, if you're a solitary fibrous tumor patient and you want to get an opinion from our team, you could do that, and then you get in the registry that way. And so we're trying to work out some of the kinks as far as getting patients that aren't at onto the registry until we have full approval. But while we're getting the approval, I think we can go in through other means.
So if somebody has, again, if they have solitary fibrous tumor, or if you're a physician listening to this and you say, hey, I think I've got a patient that has that, search up solitary fibrous tumor, Sylvester, and I will put a link when we're done with this. I'll put a link in the show notes so that we can get directly to that registry. And if I'm understanding correct, Gina, the patients who are part of University of Miami can easily register, and then folks who are outside of that system would need to either do a consultation with somebody at Sylvester or somehow kind of get tied into that system, but they could access that sort of information on the website. Is that correct?
Correct, correct.
Okay. Well,
So yes, and I can put solitary fibrous tumor Sylvester, and it should pop right up. Yeah, it'll pop
yeah. So
up.
if you just Google or other search engine solitary fibrous tumor Sylvester, you would find the registry.
Yeah,
Well, and
or you can put Horowitz solitary fibrous tumor initiative as well.
okay. Well, and that's useful information for everybody. As far as it pertains to, most people listening to this aren't going to have solitary fibrous tumor, and they may not even have a patient with solitary fibrous tumor because it's a rare disease. But sarcomas in general, these rare diseases, I think this is a strategy for coming up with answers. We make a registry. You have to get funding. We do research, and then once we understand things at the molecular level, so much more can be done. And when you're a patient like me, suddenly you go from like, okay, it's fun to understand this to like, I just am anxious for every little piece of information that comes out about it because is so impactful to my life. And, it's really kind of a interesting life to live where you're spend part of the time as a patient doing all these things and then part of the time as a physician diagnosing and treating it. And so it's interesting to kind of walk that path between both worlds. Another question for you, Gina, you've talked about funding, and what would you say to somebody else who's, another person who's interested in research and says, I have all these ideas, but I'm not sure how to get funding? Because that's been a big challenge, I think, in cancer research in general, but you were able to do it outside of an NIH grant. Do you have any tips or tricks or anything else that you would suggest for folks who are in that same situation?
Yeah, so at Sylvester, they're very accommodating, and they're really pro research. And a lot of the cancer centers do have internal funding. So, for example, when I came on, I have a startup fund that I put into my contract, right? That I have startup funds for to write clinical trials. And then we also have the Dolphins Cancer Challenge, where the Miami Dolphins have pledged to donate money for to Sylvester, and they have right now, I think, raised over 100 million for us over the years. And
Wow.
so we can use some of that fundings for some preliminary results. So you always want to have preliminary results before you apply for the grant, right? So, for example, this grant that we have, this initiative, is the preliminary results for us to be able to actually apply to maybe for a SPORE grant and get federal funding. But a federal funding, they're not going to they want you to already have these cell lines and these mouse models. They're not paying for you to develop the cell lines and the mouse models. You have to get that from other funding. Once you have the mouse models and you have the cell lines created, then you could potentially apply for the grant. So you have to have money to make it. So this is kind of like seed money, right? So, but most institutions will get emails all the time about these grants coming in. And little ones, you can get even little ones that, you just have to keep applying, and 50,000, 100,000, something like that, to they can get you to the bigger money down the road. And then also collaborating. You want to be, if you're at it in, usually obviously a researcher is going to be in an academic institution, right? So you want to always be attending the conferences and seeing who's doing what. And you may be able to lob on, or, not lob on, but, like you can maybe join someone else's already existing research projects. And if you're an academic, if you're a physician scientist, and you want to work with the PhD or the lab researcher, you want to be doing translational, even though you may not have a lot of knowledge about the molecular processes and what their experiments are doing, you have the patience. And that's key. So you
Hmm.
can contribute a lot to their research by just having patience. And so if you collaborate and you with others, then they may be able to get some fundings and you can get onto their funding, or you can contribute to that. And then eventually you get enough experience and you have enough preliminary data to actually apply for the grants. Other ways to do research. So I also am a clinical researcher. In the clinical research, you can write your own clinical trials, but you need funding for those because you need to get the drugs, and it's hard, but you can get pharmaceutical sponsored trials as well. So if you know a drug that looks very promising in sarcoma, for example, and you write the clinical trial, there are LOIs, which are letters of intent, that you can then you go to the drug company and say, listen, this drug is very promising. I can get you I can test this in sarcoma, and, can you fund this clinical trial? So you can get it through private ways as well. Other ways, you can get it through CTEP, which you can write the clinical trial, but you don't have to do the whole thing. You just do the letter, and then they will list certain drugs that they have, that they will give you, so to speak, to be able to do the trial. So there's a lot of resources. You just have to find them. You can apply for grants through ASCO. These are all cancer, but every specialty has their groups. And you just have to keep being persistent, and use your resources to your maximum.
Man, as we wrap up here, I just want to tell you thank you, Gina. I love like I say, the passion and the drive. I can tell that you love what you do and you're passionate about it. And I think whoever listens to this is going to recognize that. And, again, there's lots of people that listen to this podcast and they may find ideas, and you may find other patients with the same disease. And anyway, I just want to express my gratitude and appreciation for what you're doing and applaud you and keep up the great work. Thank you so much for what you do.
Thank you. Thank you. It's, I think the passion comes from just wanting to help, right? So
Oh, yeah.
if you love your patients, what I tell med students, you love your patients, and then you're going to do the best thing for them. You're going to be the
Yeah.
best doctor you can be if you love your patients and you care for them. You don't have to think, you just do.
Yeah,
You
that is
want
so
to.
true.
Yeah,
So true.
yeah.
Well, again, thank you so much, and hope you keep in touch and look forward to putting this podcast out. Again, everybody check out the show notes for that registry because I think that's an important piece of this. And again, Dr. Gina D'Amato, appreciate it. Talk to you later. Thank you.
We'll have to have you sign up for the registry for sure.
Sounds perfect. Thank you.
Okay, take care.
Thanks for tuning into the Doctors Making a Difference podcast. And thank you for what you do to help your patients and your community. Your work truly helps so many people. We produce this content to help you have the tools you need to stay in medicine and to highlight the amazing work being done by physicians around the world. Please note that while I am a physician and many of the guests on this program are also physicians or other professionals, the discussions on this podcast do not represent my employer or any professional organizations to which I belong. This podcast is for your information and entertainment only and should not be taken as professional advice. You should seek appropriate professional advice pertaining to your own situation. Please check out more of our content on our website, doctorsmakingadifference.com. Also, please follow, like, or subscribe on your podcast player or YouTube channel and give us a 5-star rating. It really helps to spread the message. Finally, if you'd like to be a guest on the podcast, or if you'd like to nominate someone else to be a guest, please visit the website or email admin@doctorsmakingadifference.com. See you next time.